What if the standard of care for cancer or the playbook that they're using currently has a missing critical piece of the puzzle? What if that critical piece helps with your healing in a different way that doesn't add chemicals to your body as opposed to nutraceuticals or things that the body is critically needing? What if? What if I told you that this is hopefully the trend of our future and that I'm bringing to you once again um, a doctor that refuses to believe that there's nothing we can do? And we're going to have a conversation with Dr. Sean Devlin. He is from Reno, Nevada, and he is someone I've had the privilege of sitting next to and speaking to, and just feeling how powerful his essence is to help every single one of his patients and make a difference to everybody he meets. I'm really excited because we're going to dive into the fact that perhaps there's something that we can rewrite in this standard of care. And if you are curious, perhaps this conversation in this pod class, what I'd like to call it a pod class, will make a huge difference in your life. But the 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 challenge is to be curious and not critical, and to use that to prove us wrong. Go in and dive deep. But I know you will fall in love with Dr. Devlin just as much as I have fallen in love with him. We're also going to be talking about nutraceuticals that he has helped create later in the podcast. And so today, get your pencils, your paper, because we're going to take lots of notes and learn together.
And when you need a friend, you can count on me. I'll be right here waiting for you.
Hi, my name is Lily McDermott, and I am a certified life coach. I'm a certified holistic cancer coach and the host of the Lillian McDermott radio show Classroom. If this is your first time in the classroom, please know I've been waiting for you. This is a safe place where you can go when you need a friend. It is my commitment to provide natural ways to heal, and it is my mission to make awareness, responsibility, and truth a part of our everyday life. And I hope you, my listening, as well as my viewing friend, will feel empowered to embrace a new truth and live the life of your dreams. As I mentioned, this is the second time that Dr. Sean Devlin has been in the classroom, and I want to encourage you to watch the first time that he was in as our teacher and how much we learned about integrative cancer oncology, integrative oncology for cancer. And the beauty of Dr. Sean Devlin is that if you have an autoimmune disease, you can also utilize the tools that we're going to be sharing today, or he's going to be sharing today in the classroom. And I am excited that we're going to be learning together. And since it is our sole purpose in life to give and receive love and knowledge, I am so grateful that Dr. Sean Devlin is here to do just that. Welcome, Dr. Sean, Dr. Devlin. How, I didn't even ask you, how do your patients call you?
They ask and they either call me Sean or Dr. Devlin. So
I'll call you Dr. Devlin, just because of that respect that you've earned. I love the fact that you're traditionally trained, but you've gone beyond that. And what was that moment for you that you realized I need to do more than just what I've done in medical school?
I mean, I probably had epiphanies along the way. I kind of took a unique route to even get into medical school because I was in graduate school and my goal was to do research and be a professor to teach. During that period of time, I was able to take medical school classes. And of course, you're sitting next to medical students and they're telling about all their adventures in the hospital and following doctors around and witnessing surgeries and procedures. And I think that kind of sparked an interest in me that maybe I could go to medical school and I could maybe do some of the same stuff, do a little research, teach. And then the art and science that is required to practice medicine kind of really felt very genuine to me and it felt
Mhm.
very authentic. So I think that's what kind of eventually led me to apply to medical school, go to medical school, and do what I've done since then. I mean, I hate to even say it, but like I've been practicing for 25 years. And it seems I kind of still think about like, my days playing hacky sack in the the courtyard in graduate school with students and fellow classmates, and it seems like yesterday, but at the end of the day, we're all moving through time, and it seems as you get older, it moves faster and faster. So, but that's how I ended up going in that direction, was just really about resonance and what felt authentic for me as a human, and a spiritual one at that. Feeling it out, because I knew that there was something possibly missing when I was working on my PhD, and I didn't know what it was until I started to really explore some of the aspects brought to my attention by my fellow students who were in medical school.
What was that first moment that you said, I want to look more into an integrative approach to healing? As a DO, you guys are almost there, or at least that was the difference between an MD and a DO, where I thought, there was more of a natural progression with a DO as opposed to an MD, which is more allopathic. Was there a moment for you that even as a DO, you felt that you needed to look more into homeopathy or anything to that effect?
Yeah, I would say that during medical school itself, we were introduced to topics that might be considered esoteric, but there was a little bit more, I guess, liberty being taken in some of that coursework. But it's all the same coursework that you would normally get in an allopathic school. In fact, you have to take. There's no choice now. It's all ACGME, but ultimately, the osteopathic course allowed me to hone skills that I had experienced as a kid because my family doctor was an osteopath. And so there was a lot of touch involved, manual therapies. And I think the founder of osteopathy, Andrew Taylor, still really embrace the concept that the structure and function were so grossly interrelated they couldn't be sort of separated and isolated. And systems, even though we silo systems and we have all of our specialties have siloed these systems in a sense that we have, cardiologists focused on the heart, pulmonologists focused on the lung, neurologists focused on the nervous system, that they kind of said, listen, this is all stuff that's integrated within this human being. We want to know how it talks to each other, how it interrelates to its environment. And part and parcel, Andrew Taylor Still, who literally probably at that point in time in the 1800s had done the most cadaver dissections with he and his colleagues ever done before, probably in the history of all medicine, not knowing specifically what was recorded during the time of Hippocrates or Galen. These are things that were documented by him and are housed in the museum at the Kirksville College in Kirksville, Missouri. So I know for a fact my introduction came through that path, and just I guess being more open-minded and kind of I listened a lot to stuff that at first I thought was a little bit outlandish.
Woo
Um,
woo.
yeah, woo woo. But with further exploration, I started
Yes.
to come to understand
Yeah.
that yeah, facts.
I just had a conversation with Dr. Henning Salpa, and I was saying to him, that there's so many times in my life that I made fun of people like me right now. That I started down this journey for me to prove somebody wrong that was saying that we give ourselves cancer. I don't know if you know who Dr. Lorraine Day was, and but Dr. Lorraine Day was like the first time she came on my radio show. I swore I'd never have her back, but she later came back, and because I had to prove her wrong, I had to keep researching, and it became my truth, not her truth. And that just opened up a huge door. When the student is ready, the teacher appears, and that opened a whole new place for me to be open to doctors that are integrative, holistic, and functional, to the point where that's all I want to do right now. But if there's a place for everybody, there's a place for everything, but I just love the combination of Eastern and Western and what is out there. You and I were talking before we got on, because I was saying, there are doctors that tell their patients there's nothing we can do. There's nothing we can do. What is your advice to a patient, a person that is getting there's nothing we can do for you in the allopathic realm? There's nothing we can do for you. What comes to mind if I came to you and said this, that this, my doctor just said this to me, and I am coming to you as my last resort?
Well, I would say let's see. We'll see if this is the truth or not. I mean, none of us have crystal balls, right? So none of us can forecast the future for any given patient.
Yeah.
My conversations really come about by have we done everything to completely understand the cancer itself, the tumor biology, the tumor microenvironment? Have we come to understand what the patient wants, desires, or needs? I've taken care of patients who have been told that there's nothing left to be done and that they need to kind of get their affairs in order. They've
Mm-hmm.
gone through, multiple cycles of chemo, radiation. Maybe they've had multiple surgeries, and they've been told we've exhausted the resources that traditional oncology has. And then they sit in front of me, and I say maybe that's true, but I think we can do further exploration. And what's nice about today's laboratory technology is that we can do deep dives into the patient's
Mm-hmm.
tumor genetics, their own personal genetics, and have a better understanding of causative factors, right? What could have contributed to the cancer forming in the first place? Number two, what Achilles heels exist for the cancer, what's driving the cancer, have the brakes come off, in other words, is there something that's either impugning the ability for the body to recognize and go after the cancer, or has the cancer basically just become, a speedy vehicle pursuing, all aspects of the human body to infest? And I've seen that, and we're seeing that more and more. And I know a lot of people are talking about, this turbo cancer, this revved up
Mm-hmm.
cancer. I mean, we're seeing cancer in younger and younger people, and we're seeing cancer that is very aggressive, going through stages very quickly, or being diagnosed at a late stage, because they had no symptoms prior, to that point in time.
Well, we're seeing that in so many ways. So today's class is about breaking the mold, breaking out of this standard of care that is about cutting and burning and toxicity. So if that were the only thing, the only solution, if that's the only thing that we have in our toolbox, eventually some things will work, some things won't work. But if we had a bigger toolbox that would give us an opportunity to maybe add to our body things that we need. So, with that in mind, when somebody comes to you with a cancer diagnosis or an autoimmune condition, what are some of the things that you look at? I know that you mentioned some of the tools that are out there, blood and all that. Does everybody go through the same process, or do you tailor it as you're listening to the individual, or what kind of cancer it is? How do you decide how to assess?
Yeah, it's a good question. Everyone is sort of an N of one, and I always say I'm trying to treat you as personalized as I can. And to do that, I have to gather information not only from them about their history and
Hmm.
background,
Yeah.
clinically where they're at, what's the stage of the disease, what has been done in the past, what might have worked, and even, a partial remission or disease reduction is considered a win. It may not be winning the war, but you've won a battle. And I think some of the concepts that we go through on these initial intakes is talking about expectations and understanding their desires and acknowledging and respecting their autonomy, no matter what comes of the conversation. Because some people come to me and they have very esoteric belief systems, and I'm not there to challenge them or to, shame them in any way, but I also am there to educate them. I think patient autonomy is important, but an uneducated patient, their autonomy is limited, right? And going back to some of the words you use, the cut, burn, poison, that has been a moniker that surrounded traditional oncology for quite some time. And I'm trying to dilute that phraseology because it scares people away from getting what could be life-saving care. And as an integrative oncology practitioner, my goal is to give best of care no matter where those tools are coming from. And a lot of times I have to redirect them back to traditional oncology because they haven't given it a fair shot, or they haven't done it in a way where we can take advantage of some of those same mechanisms, whether it be with chemotherapy, radiation combined with hyperthermia, surgery supported before and after, resampling tumors. I think that's something where we kind of miss a beat. We don't learn enough about the tumor on the first go around, or the pathology is isolated, or the sample isn't robust, that we have to go back and take another look and see if the tumor has changed and if there's new targets that we can go after. I think a lot of that stuff is happening more and more within the traditional oncology realm. It's certainly been promoted within the integrative oncology realm because we're looking to explore every single stone and what lives under it so that we don't miss something where we later look back and go, gosh, I sure wish I knew they had that mutation. They would have been a candidate for this repurposed medication or targeted therapy. So that's kind of the conversations that we have. That's how they go. But the main thing for me is to have a better understanding what the patient wants. And sometimes my patient and I, we don't resonate. There's not a match, and they will go on to seek care from other providers, or if they do stay, it will be with just limited interventions on our part, because they don't want more than that. And I'm very honest. I tell them what my expectations are. And I mean, I have some people who just want to change their diet and do some, psychological therapy in the hopes to get rid of stage 4 cancer. And is it possible? Yeah, we consider those to be basically spontaneous remissions. I have seen people who have had prolonged their lives by changing their diet and doing things as far as their lifestyle goes. But to make a big impact on a regular basis, you got to have basically a lot of tools being employed for the benefit of the patient.
Now, I was at an event that you were at, and you were part of the panel. And the topic, and I believe you were part of that panel when the topic of blood testing, testing for pharmacogenomics, testing to see what kind of drugs are available for that particular individual that the body will tolerate, or whether or not the patient has any staging or where they're at as far as the cancer process. Do you have a particular place where you feel is the best place to go to, or are you still looking at, possibilities that could be better for people?
That's another good question. And that was sort of a hot topic item. I think it's very challenging because I mean, I have a lot of really wonderful colleagues in the community of integrative
Mhm.
oncology who are doing the best they can with the
Yeah.
tools they have. However, sometimes tools can be misrepresented to us. And I've been in situations where I have gotten tests and then I've sort of test the test. And when I do that, I come to find out, sensitivity, specificity is lacking. The test then becomes really unreliable. It's just like throwing not so good information into the mix. And then if that changes how you direct your course of treatment or care recommendations, that can be, I mean, life-threatening. So I've been very adamant about visiting labs that I use regularly, doing chain of custody walkthroughs with samples that are sent in. And one of the first companies I did that with actually was Caris out of Arizona, and they're really one of the founders and pioneers in the area of next generation sequencing for tumor genetics, and they've done a phenomenal job at moving the field forward. Since then, there literally have been several dozen other companies to follow in their footsteps. Some of them doing just phenomenal work and making it really cost effective for patients to get, circulating tumor cell information, circulating tumor cell DNA information, as well as solid tumor next generation sequencing genetic data. I would say I use a compilation of those tests. What I like to see is when I get two different tests and they share the same data with me coming from two different labs, that reassures me that I'm going in the right direction if I'm recommending a targeted therapy or a form of immunotherapy that would be to their benefit.
When I look at when I'm working with somebody, or they're trying to make a decision on what direction to go in, I always tell them not to make a decision based on what they will pay the insurance company, like what the insurance company is saying is acceptable. Let's say they have an insurance company and they only look at one direction, and they're concerned about cost. Because it sounds like there's a lot of testing that needs to be done. What is your advice when it comes to that kind of testing, especially when people are concerned about the financial aspect of it?
Yeah, I have some patients who have great means and money is not an issue. And then I have patients who are very restricted on what they can spend. And I would say that regular testing is important as long as it's going to generate an actionable result.
Mhm.
In general, most of the testing companies I use work very well with our patients. And in some cases, there's little to no cost to them, and they'll process as much as they can through the traditional insurance model,
Right.
and more insurances are accepting these
Good.
labs because what they're generating is sensitive and specific and is worthy of being paid for because it's generating data that can alter the outcome of a patient's case. So, yeah, I just reassure them. A lot of times in the early days, the patients would get bills. I remember one bill for like $36,000, and I'm like, let's call the company and talk. And they're like, no, 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 we have to send that out, but we just basically write that cost off as long as the patient signs off and gives them permission to use their genetic information anonymously for further research. And to be honest with you, with the advent of AI over the past several years, more and more of this data is being crunched by AI systems in an effort to create almost like predictability models of how a given patient with a given genetics is going to respond to a given targeted therapy. So it's really an exciting time. And part and parcel, a lot of that legwork was done by some of these companies over the past, decade to 2 decades. And kudos to them for putting in the money and effort to make that happen, because patients are going to benefit here in the near future by that full integration.
So how is AI? I mean, because I mean I've heard how AI, now we're hearing in the news all the time that AI is the next best thing for us. How is AI going to be able to help us with disease? I just, there's a difference between putting in a topic in Chat GPT versus having AI look at your sequencing or your blood, whatever it is, to predict what could happen in the future. Is that what I heard you just say?
Yeah, exactly. And that's happening. And there's several large universities that have their own separate systems that they're employing. And these large language models have been able to allow us to crunch through massive amounts of data. I mean, like literally what
Really?
physicians would do in a lifetime, these systems are doing in mere minutes. So,
Wow.
yeah, and I mean, there's this quantum chip that just got developed, this Willow chip, and they're going to be able to the processing speeds are so high they're near unimaginable. So at some point in time in the near future, certainly with the integration of electronic medical records, electronic health records with AI, with these deep databases, you are going to be able to make predictable statements instead of like, I wish I had a crystal ball. You're going to be like, technically, we kind of have a crystal ball. And I can tell you now by planning out your course of care involving NCCN guidelines, possibly clinical trials, possibly repurposed drugs, possibly supplements, maybe radiation, hyperthermia, surgery. They can sort of tell you like when to do what, when based on genetics, and you can update that system with new data as you gather new biopsy material, new circulating tumor cell DNA. All that stuff is going to be, it's almost like a dance throughout time where you fine tune therapy to that person's need within that window of time that you're providing it.
Wow.
And that's kind of where medicine's heading. I mean, we really are. I mean, we're on the precipice. In the past probably 5 years, my experience with AI went from, well, good luck. We'll see what happens, to now I'm like, I use it regularly and I'm very impressed.
Really?
Yep.
Really? So help me understand. Do you use it to input information for your patients, and then it gives you a probability or an idea of what to do with that individual?
Yeah, well, for sure it can give you basic stats, but those are going to come from the NCCN. They're going to come from ASCO. We have this data already.
Mhm.
I mean, Up to Date, which is a common resource used by many clinicians, is pretty good and accurate with those things. But these are all retrospective, right? We're talking about from 2025 backwards. We can say, hey, listen, if you have pancreatic cancer, you have X number of months to live, right?
Mhm.
And at the end of the day, it falls within some, realm of reality. People who rely on that data are really actuarial, folks that are, doing life insurance policies or, determining when somebody might pass from a given illness. But in this case, I'm using AI not only to look at the literature to see what's been published or yet even pre-published, to pulling up information on, I mean, it's kind of weird to even say this, but like what supplement and maybe prescription drug might work best for this patient who has pancreatic cancer? Where is the data, and how would I rank the data? Is it,
Wow. Okay.
double blind, placebo controlled? Is it an expert opinion? There's minimal middle of the road kind of evidence? But yeah, that's the kind of stuff we're doing now. But to be able to prognosticate beyond that, we're not there yet. But that's where we're heading. There are systems now being built that can help guide the oncologist's hand as far as what care should be given and when.
It's interesting because many, many years ago, when DNA testing, pharmacogenomics started happening, or I was tested for the dementia gene, ApoE or whatever, I remember people were telling me like BRCA gene testing and all those. I would say, don't if you have the gene, use it as a way to prevent. Use it as a way not to say 50% of people that have this gene are going to get cancer, therefore I'm going to get cancer. I'm going to take away my body parts so that I don't get cancer. I would say, can we prevent, even though you have the gene mutation, how can people prevent it and use these tests for prevention? And use it as this is a potential that could happen. Is that something that you can use AI for as well?
For sure. I mean, that's part and parcel, part of doing a good sort of a functional medicine workup, or, lifestyle medicine is another thing that's really evolving, where we look at, patients' personal genetics to
Mhm.
know whether or not they're going to develop Alzheimer's or diabetes or some, future form of cancer. I mean, we have really common ones, people with Lynch syndrome get these GI cancers, people with BRCA1, BRCA2, they end up with breast and ovarian cancer. ApoE4, those mutations, I mean, God bless him, but Chris Hemsworth, when he was part of that Peter Attia special, it was determined that he had ApoE4 mutations and is at high risk for developing Alzheimer's. I think that knowledge is core to help you guiding
Yeah,
therapies now and taking preventative steps to ward off some of those,
exactly.
genetic inscriptions that may show up in your future.
I totally agree. I totally agree. And I wish people would use it as that because it's our lifestyle. You have your genes, but the lifestyle is what pulls the trigger, right? It's
Yeah.
the way we believe, we think, and all these past traumas. And so I think that some people were using it to be scared and take an action that they could have waited for. But everybody's different. Everybody's got their own path. One of the things that you said that when somebody comes to you, you talk about expectations. But do you also share with your patient what your expectation is for their action? Do you expect anything from them or do you not expect anything from them? When you're dealing with oncology, integrative oncology, what is your expectation of the patient?
Yeah, I think initially when I meet patients, I want to develop a rapport with them so there's some mutual trust. I don't have all the answers, and I know that they don't maybe have all the skills and capacity to comply 100%, 100% of the time. But I want them to be willing to buy into the process, knowing that there's going to be regular, timely interval tests that are going to provide feedback as to whether or not what I'm recommending and what they're doing is working. And I think once you start to build that ladder, you can ascend through this disease process and end up in a really good space. If you sort of play your cards right, and playing your cards right is kind of being compliant with the recommendations that are being made, whether it be by myself or by a team of clinicians. And it really does. It takes a team of practitioners to take care of folks with cancer. And I certainly do not want to be one man on one island all alone. And to have a village of people to support that patient is critically important, from family members, caregivers, the nursing staff, the infusion techs, the fellow folks that are taking care of people in the hospital if they get sick, in the emergency room, the surgeons, radiation oncologists, the oncologists themselves. All those folks are critical to my patient having a positive outcome. And how we get there, it's unique. I don't think there's any patient that I can compare with another that took exactly all the same steps and had the exact same outcome. Every patient has been on their own path.
And as you look at them, you know that they're coming to you, you're starting fresh every time, or do you say, okay, this is another pancreatic cancer, or this is another, diabetes, or this is another. Do you have like protocols established at this point after 25 years of where to look, where to start?
Well, yeah, of course. I mean, we do have some basic protocols, but the thing is that you have to do a deep dive with, laboratory testing, imaging, taking a good history, performing a physical exam where you examine the patient, all the things that I think are really important and in some ways are a dying part of the art of medicine. I learn a lot during these encounters with my patients, and in the process, if certain tests haven't been done, we'll get those ordered. A lot of times it's going to be NGS studies or maybe tumor staining or other further biopsies that might be required. If somebody had a biopsy 3 years ago and still has a tumor present and has been through a multitude of therapies, my guess is that that tumor has changed to some degree and is expressing different genetics. So I either am going to rebiopsy that or I'm going to look for shed tumor cell DNA. And if that cell-free DNA demonstrates that there's other targets potentially available, then we'll discuss what medications would be appropriate or interventions would be appropriate to treat those findings.
Okay, since you mentioned biopsy, there is a school of there's thought that a biopsy is a way to predict what's going on. You know what's happening within that particular cell or that area where there's cancer. But then there's another school of thought that says that if you when there's a tumor that's encapsulated and you puncture it, it releases cancer cells into the body. Where do you fall into the research of biopsy versus no biopsy?
Yeah, so without a biopsy, technically you do not have a pathologic specimen to reliably base a diagnosis. So for information purposes, I'm a big fan of getting biopsies. The misnomer is it's almost like nobody talks about the good news. Everyone talks about the bad news. Good news is the majority of biopsies don't spread disease. The only time that we've seen, and I've seen in the literature, there's been a couple cases of where there's big bulky tumors that were biopsied, and it's still yet to be debated whether that tract got infested with some cancerous cells. In general, this is not the case. Um, a morselization of uterine tumors, unfortunately, when they're not clearly identified, has led to the spread of cancers, including things like rhabdomyosarcoma, that when you think you have just fibroids in a uterus and you morselize that to prevent an open surgery and suck it out through some little holes in the abdominal wall, that's where you can have a problem, and that's where we have documented problems. So we don't really, there's no more morselization of these masses anymore. They get pulled out and
Have they
pulled.
stopped doing that?
They
I
have,
heard
yeah. That's
that's
not, yeah,
horrible,
yeah,
horrible that they were doing this to women.
yeah,
I don't know if they did that with men, but I know for a fact that women were going through this when they were removing their uterus or ovaries or whatever it was that they were trying to remove. It
yeah,
was usually spreading and causing some terrible things. So I'm glad to hear that they've stopped doing that.
yeah.
Great concept, but it just didn't. Unfortunately, some people had to die to prove that the theory was not good.
Yeah.
But okay,
But you
so
bring, yeah, you bring up a good point, and I think that I want to demystify the whole biopsy concept because at the
yes,
end
I
of the
do.
day, biopsies are super important, and I wouldn't have anybody doubt them or be reluctant to get them if it can provide life-saving information.
Even for the prostate is so small, it's a small area. We've heard that the former president has prostate cancer, went a long period of time where nobody even checked his PSA count or anything to that effect. And now he's got advanced stage cancer,
Yeah.
prostate cancer. So, with that in mind, I mean, it's so hard to believe that someone who has the means to have all this testing would not even know until it's advanced, but not to judge it. I'm just saying it's just it was shocking to me to hear something like this. In that situation, was he did a biopsy prove all this that this was the situation with him, or could a blood test do it?
Yeah, it's a good question. So that's been a hot topic in the media. President Biden unfortunately has been diagnosed with stage 4 prostate cancer. And I think his Gleason score was 9.
9.
I know there's been some misinformation that was spread out there, but ultimately, because of his age, they stopped screening his PSA. And this is based on basically US recommendations for screening purposes. The thought is when you look back in time, the chances of somebody at his age having prostate cancer is already high. I mean, he has a high risk of developing prostate cancer, having prostate cancer at 80+%. Ultimately, the question is, what will take him from this world? Is it going to be the prostate cancer, or will it be something else? Will he have a heart attack, a stroke, infectious disease? Will that kill him? We don't know. But at the end of the day, stage 4 prostate cancer is treatable. I mean, they can treat it and keep it at bay for a long period of time so that he may live a few more years and die of something else.
Hmm.
My fear is, that he dies from complications of Alzheimer's disease, right? I
Hmm.
think he suffers from some dementia and that may eventually catch up with him. But yeah, you ask a great question. And a biopsy, I'm assuming they did do a biopsy because they have a Gleason score,
Hmm.
and that's how you get those. So
Ah.
I think that the only way to really confirm what was going on was to get the biopsy. I presume on ultrasound or on MRI, they found an irregularity in his prostate. They biopsied it, and they found with a bone scan or a CT PET scan, they found that he had Mets to the bone. So,
Well, it's one of those, it's like you hear a good argument at no, 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 do not do biopsies, and then you hear a good argument that it's a very important. How else are you going to know what's going on unless it's done? So, does it need to be done in a certain way? I mean, you've already talked about that there's ways that have risk the body from getting more cancer. But have they established some protocols of where to, like with prostate cancer, let's just look at
mhm,
that. It's a small area that gets kind of a little angry when you start checking in different areas and you're
mhm.
just basically taking little tiny little slivers. Could that make things worse, especially when it's such a tiny little area?
Yeah, I mean, you bring up a good point. I mean, there's literature out there actually to suggest that sometimes when you biopsy certain tissues, you can actually instigate an immune response, and that
Yeah.
could be potentially beneficial to the
Hmm.
patient. And then on the flip side, there's information that, hey, do you create a pro-inflammatory environment, and is now that pro-inflammatory environment going to set fire to that cancer? Is it going to start to grow and do things? I don't think we have enough data to say that's exactly what's happening. Certainly when you look at prostate cancer, the majority is going to be androgen sensitive. So almost immediately you can start doing a therapy on them, right? You can start to block that testosterone or create a space so that you're not getting pressure from whatever testosterone's in the system to keep that cancer growing. And then ultimately, besides, surgery, radiation, and some chemotherapy, there's, other tools out there to treat prostate cancer. But for us, I do a lot of I sort of prep patients with certain protocols to make sure that whatever biopsy experience they have is the best. And then in their recovery, I mean, I've had some patients who have had prostate cancer diagnoses through these biopsies have profound bleeding for several weeks. And then those who have gotten pre-treated and then post-treatment do very well with minimal to no bleeding after, a prostate biopsy.
What are these
Um,
suggestions? What are these suggestions for pre-treatment before prostate?
Well, sometimes if they can come off any thinners, any blood thinners they're on, I take them off of that. I'm a big fan of, IV vitamin C. So pre-treatment with IV vitamin C before and after, because you are causing a trauma, you can help heal that trauma a little quicker by having some IV vitamin C on board. A lot of times I promote patients if they can be in a fasted state when they go through this process, generally
Oh.
24 to 36 hours can be beneficial. And then during their recovery time, to be able to participate in directed therapy. So that would be everything from looking at our repurposed drug profiles to anything that would intervene on the pressure being put on it by testosterone. So a lot of folks will go, directly to giving Lupron. There's some old school drugs that people might start on, and some urologists are in agreement with this, starting somebody on like Casodex orally and then transitioning them to a shot, so it's less of a compliance issue, or prepping them for what it might be a prostatectomy or a radiation of the prostate. So
And and
there's
if and if a man doesn't want to do that, if they don't want to remove their prostate because it leads to other things, it leads to incontinence, it leads
yeah.
to other things that might be difficult. I know that having cancer in the prostate is slow growing. Would there be a situation where you would say, lifestyle supplements, nutraceuticals, like you're talking about IV, could that take the place of chemotherapy and radiation?
Yeah, we don't have the data on that to suggest. I think it's helpful. A lot of times we'll integrate these things and overlap them.
Hmm.
Very rarely do I have patients completely denounce any form of androgen deprivation therapy because they know the benefit. And very quickly you'll see defervescence of PSA. You'll see improvement in their symptoms clinically if they're having signs of BPH. And ultimately, the goal is to keep that disease at bay for as long as possible. In the older male, 75 plus, I would say they have more options when it comes to approaching things in a less dramatic way. But we're seeing prostate cancer in young men in their 40s and 50s and early 60s that, they have another 20 plus years of life in them. And sometimes we have to get a little bit more aggressive. And in doing so, employ some of the other tools that people may not want to buy into. But really, between urologies using Da Vinci to guide prostatectomies, we've come a long way. A lot of nerve sparing procedures have been done, and patients maintain continence and erectile capacity. And then same with radiation. There's ways that they've gone about doing it to really prevent some of this neurovascular injury that had occurred in the past. And there's ways to mitigate some of that radiation injury using integrative tools. My goal is their goal. So if they're like, if I piss my pants and can't get an erection, I will take my own life. Well, what am I going to do with that, right? Because if I start to employ some of these heavy hitters, they're going to have some complications in that arena. So I want to really be mindful of where their head's at and to make sure that they've learned about all the potential options and the outcomes if they do not choose to do X, Y, or Z. And I'm seeing this a lot, unfortunately, with younger folks because of this concept of andropause, right? So men who have testosterone levels, in the 200s, maybe low 300s, and are symptomatic of maybe not having the same sort of virility or stamina or strength that they had in their early 20s are now being placed on testosterone. And I think we're getting into a position where we're creating some problems downstream if we're not monitoring these patients well enough. I've seen several sort of lifestyle slash age management doctors come out and say, hey, listen, the risks of taking and supplementing testosterone in somebody who's truly an andropause outweighs the potential risks of developing prostate cancer. Unfortunately, my perspective is a little different because I'm seeing these younger men with prostate cancer, with Mets to the bone, who their lives are cut short because of that supplementation. And a lot of times this testosterone isn't managed well, right? So these guys are like, wow, I'm like a total stud. I'm working out for 3 hours in the gym, I'm hooking up with all these ladies, and the next thing you know, they've got problems, and that's because their average, circulating testosterone levels are greater than 1500, and nobody's monitoring them. They're just getting their shots or their pellets, and they're, hey, go do your stuff and take care. I mean, nobody's really looked at this closely enough to say, hey, are we causing more problems than helping these folks?
I love that you're not married to a solution. I mean, you're not married to a particular process. You're just wanting a solution for them. And you offer all so many different options for people. And I really do appreciate that about you. And I wanna continue this conversation. I want to talk about the fact that Dr. Sean Devlin's been on in the classroom before. We talked about integrative oncology and the benefits and how you can use the best of both worlds to what works best for you. And so check out the conversation. Go to whenyounneedafriend.com. While you're there, please subscribe to the website. If you need any of Dr. Sean Devlin's information, you will find it in my blog. I mean, we still haven't even dipped our toe in the surface in this in the in into the water because there's just so much that he can add to our conversation. But I want to encourage you to go to whenyouneedafriend.com. Please subscribe to my channel, subscribe to my social media, as well as support the sponsors of the classroom, support them the way that they are supporting the classroom. I have a Shop Now bag that has Lilly approved products from head to toe. That's a way you can help the classroom grow. And you can also go to become an enrolled student in the classroom, whether it's $1 or $1,000 a month, a one-time donation of whatever it is, your time, your talent, your treasure will help us grow. Sharing this video with a friend, someone that you know. We all know somebody who has cancer. If it's not you, it's somebody that you know. And so I just want to encourage you to continue to share this information so that people are in choice. They're given them informed. They have informed decision because they have the right choices for them. So I want to continue to ask for your support. So help us grow by sharing this video and making sure that you support Dr. Devlin as well. Dr. Devlin, the last time you came to the classroom, you had talked about some nutraceuticals that you had formulated, and you sent them to me. And I wanted to talk about the different formularies. These are some nutraceuticals. Do you put all your patients on these, or is it depending on their need?
Yeah, that's a good question. It depends on their need. I think it's sort of a long story, but many years ago, I was doing research on the endocannabinoid system, right? And so
Mhm.
I studied how this system was impacted by exogenous cannabinoids. And from a medical perspective, I found it really fascinating that there was a myriad of benefits found in cannabinoid ingestion, right? So there's,
Mhm.
the good, bad, and ugly of cannabis, right? Medical marijuana has been through many phases, and now it's legal in more than half the U.S. states, and it also has a recreational foothold. But really, at the end of the day, for me, when I was taking care of a lot of patients who were on chronic pain meds, I was kind of forced to look at harm reduction. I said, how can I get patients off of some of these medications in a way that not only protects them, but preserves their risk of potentially overdosing or having complications from being on chronic pain meds? And I was very successful at doing that. And part and parcel that led to the development of some of the protocols that we put into these supplements. And so I came together after I was helped launch a couple cannabis companies, and in the process, started putting together these cocktails. And they were basically in the hopes of creating a big C formula, right? My big C formula is going to be involving a variety of things that demonstrated activity against cancer cells that could be well tolerated by the general population. Well, that didn't come to fruition because there was no market space for it, and I was advised to go in a different direction. And during that, I basically talked to some of my colleagues who are in medicine, and they said, listen, what are the top sort of 5 things we see in primary care medicine
Mhm.
that we could address with a nutraceutical cocktail? And so it really came out of that conversation that we developed the 5 products we have now. And one of them is for pain. That one's for viruses, right? That came right on the launch of COVID, so in 2020, and then the
This is the
sleep.
one I was taking. This was the
Yep,
sleep formula.
yep,
And of course, this is the pain formula. So tell us about
and
the pain
pain. Yep.
formula, because a lot of people with cancer have pain. And it's like this time has just blown. And I want to tell you, my son took the focus formula and the anxiety formula. He took it from me. And he has ADHD, or was diagnosed with ADHD. And after a while, you know how sometimes we self-medicate to help with the focus or whatever it is. But he started taking those nutraceuticals, and he said, I could tell a difference right away. He could tell, and it gave him the desire to do more and to stay focused. And then, of course, the focus with the anxiety helped him kind of like not need to self-medicate. And so, can you share a little bit about the formularies and how it's benefiting your patients?
Yeah, and this is, it's kind of funny because I'm not like a big self-promotion guy, but I'm very proud of the formulas. And I think one of the hardest
They're
things we
great.
did was capture sources of these supplements in spaces that were really clean. In fact, we ended up we paid like through the nose to get the best curcumin, to get the cleanest CBD, and we went through almost every single herb and sourced it from a really clean place, and it was put together in a pharmaceutical grade lab, and the company did a phenomenal job in generating these products. I think one of our best selling products is actually the sleep, and the sleep is remarkable. It really helps people get sustained sleep, REM sleep, and to the best degree possible, wake up without feeling drowsy or hungover. The focus formula came about because a lot of people had been,
Chemo brain.
yeah, struggling with brain fog and a lack of cognitive capacity. So we looked at a bunch of different adaptogens, even a little bit of caffeine and ginseng, and the list goes on. But there's a variety of compounds in there that help people maintain focus on whatever they're working on, whatever task. And then the anxiety formula sort of puts people into a more of a parasympathetic state and out of this sort of low grade PTSD where they're chronically in a sympathetic overdrive. And people who combine the two have reported back some very good success in being able to work at school tasks, job tasks, projects. So we've been happy about all that stuff. And again, the pain one basically covers a wide variety of pathways, including pro-inflammatory pathways, and dealing with C fiber transmissions. Yeah, so all those, and they have a lot of things that you would commonly see in some of their products, but the cocktail is metered out in such a way that you get a lot of synergy and entourage effect. And so we try to maximize, even though it's not a lot of certain supplements, it's the mixture of those supplements that make it potent.
I tell you what, my son was very, very complimentary as well because, he's tried other things for focus and he just when I asked him, I actually asked him today. I said, Blake, how did you like it? Remember that bottle I gave you a while ago? I say he took it, but I gave it to him. And he said, I really loved it. It's a great product. He really loved it. Took that edge off. And so I want to encourage all of you to look into it. The website is Lig and Scepter. So it's LIGANDCEPTOR right there. So see it right there, right there. And if you are a subscriber of the channel, then you already have the link. It'll take you straight there if you would like to, if you're interested in getting your own supplements. I know that there's like 4 minutes left in the classroom here. Um, some of the other supplements that are a must that maybe you take yourself or you encourage everybody to take, what would you say are those?
There's a long list, of course. I mean, I'm a big fan of maintaining adequate vitamin D3 levels, certainly for prevention of a variety of illnesses, from diabetes to infectious disease. The other ones that I really enjoy, I use melatonin, milk thistle, quercetin, curcumin. I take a NAD precursor. I think one of the other important supplements that's out there is Boswellia, that can help with inflammation. But those are kind of the capstone things that I use. I use repurposed medications. I think they're very powerful. We're still collecting data on metformin and berberine for
Mhm.
everything from mitigating metabolic syndrome to even preventing cancers and diabetics. And as that data grows, I think we're going to start to see some uh, aging benefits to the use of things like metformin. And I also believe these GLP-1, GIP agents are also going to provide some benefit for those folks who are either insulin insensitive, pre-diabetic, or diabetic for long-term aging phenomenon. I mean, what we're seeing, whether it be from addiction issues to fatty liver, to maintaining healthy hemoglobin A1Cs,
Mhm.
we're still gathering data, but it looks very promising. So I'm excited to see what comes down the pipeline. I know there's several drug companies now working on the concept of sarcopenia and addressing it. So there's agents that will probably be coming down the pipeline for building and preserving lean muscle mass for those folks who are on those agents or who are in the process of losing weight. And this, of course, will help with folks with cachexia that have muscle wasting secondary to their progressive cancer.
Very nice. Okay, so if somebody wanted to contact you, would they contact you at the gerbermed.com? And or do you have a clinic where they can go to? How would somebody be able to spend time with you, Dr. Devlin?
Yeah, so we have a sort of a regular clinic in Reno, and that's the Gerber Medical Clinic, and that folks can reach me there directly either through the website or by calling the office. And then ultimately, I still do a lot of consulting and teaching and telemedicine, so I can engage through that office platform to do phone visits, Zoom visits, and then I'm still traveling to teach. So I'm regularly going to places like Colorado and New York and Arizona and doing collaboration with fellow physicians who want to get involved in doing integrative oncology and functional medicine in general. I think it's really important. It's a growing field, and there's a growing desire. Unfortunately, I don't think we're able to meet everyone's needs and wants because
Mhm.
there's not enough clinicians to go around.
Yeah, yeah. Well, I'm glad to hear that you're out there teaching because I know that there's a lot of people that are benefiting from that. What's the final word of hope? What can you share with us as we leave this podcast with hope?
Yeah, things are changing so rapidly in 2025 that I think the next 5 years, this moonshot mission for dealing with cancer may really come to fruition. Immunotherapy has been a big thing that I focused on, as well as these antibody drug conjugates that are being developed very rapidly, long pipelines with lots of produced product coming out there to help us better target cancer. So if you get diagnosed in 2025 with advanced stage cancer, I would feel hopeful in the fact that we have solutions for you and putting together a great care team and getting some good quarterbacks on your side to help guide your therapy is going to allow you to have the kind of outcome you want, not just quality of life, but quantity of life. So there is hope. And as the future unfolds and we integrate more AI and more research is developed in this arena, I do think that cancer is something that hopefully in my lifetime we can really put in the rearview mirror.
Oh, that would be great. Or at least treat it like a cold. Like, oh, okay, well, I
Yeah.
got to take some extra vitamin C, get on some Liganceptor. Do something to that effect where it's not as crazy as it's been and lose so many lives when they could have been prevented. So I want to thank you for all the work that you've done. I wish we could go on another hour and maybe we can have you back sooner as opposed to later and so that you can continue to teach us. But I really appreciate the work that you're doing and listening to your patients to the point where you're trying to get them out of pain naturally without all the chemicals that can cause other problems as well. So I want to thank you for that as well. And I'm sure everybody that has worked with you appreciates you. So thank you.
Yeah, my pleasure. Thank you, Lily.
Yes. And please remember, you're in choice. You're always in choice. This is Lillian McDermott and Dr. Sean Devlin wishing you love, peace, joy, and unexpected abundance. Make it the best day
Ever.
Good job. Good job. That was the best one ever.
The opinions and advice expressed on the Lillian McDermott radio show are intended for the individual callers and guests on the program and are presented to our wider audience solely for general educational purposes. Please act responsibly and consult personally with your own medical, psychological, or nutritional expert before taking any steps to improve your life.